Good evening, I'm Dr. Joe Matthew, and today I'm going to talk to you a little bit about treatment planning or treatment strategies for the potentially complete denture patient. I've titled this little talk as Catching Them Early because if you can catch the potential complete denture patient early on, then you could reduce the chance of compromise in your prosthodontic treatment. We all know that you don't usually find an elderly patient who is geriatric and having a good healthy lifestyle, having a well composed social function, coming into a place where they need complete extractions. Usually not, because they still retain some element of social understanding of the need for their teeth. They still retain some element of dexterity to be able to manage and maintain the oral hygiene and things like that. It is usually the patients who are a little bit compromised in certain areas that are actually moving towards total extraction. So the point here becomes, is it perchance that the patient neglected care for some reason or the other and has come to the state but is now willing to take care? So the importance lies in the willingness and the attitude of the patient to be able to retain and maintain what is retained. If the patient is willing for that, then only we should start thinking about any of the treatments that I'm talking about today. Otherwise, if the patient is not able to maintain it, all our efforts can go in vain very fast. So it's very important to catch them early, to educate them when they are in a place where they can understand what you're talking about and they have a desire and the motivation to maintain it. So the patients that come into our clinic are going to be primarily of two categories. Either they are partially edentulous patients or they are completely edentulous patients. If the patient is completely edentulous, then that means obviously that we have in some sense lost the opportunity to catch them early. Or if the patient is just extracted, maybe his or her teeth, maybe we are in a place that we are able to salvage some of the problems that this patient has and give a prosthodontic solution which is not much compromised. So the first scenario is the partially edentulous patient. Here obviously medical compromise is going to be an issue. We need to know if the patient is medically compromised. Medical compromise can vary from a slight condition that is common in our society like hypertension or diabetes, which is well controlled, or it can vary even in those conditions to a brittle stage where they are not at all well controlled, and so treatment needs to be deferred and maybe more vital treatment in that area needs to be administered first. So as you know that if there's a mild to moderate cases of hypertension or diabetes or some age-related diseases or diseases that have predilection for the age, then you're going to still go ahead with your treatment as long as it is well controlled. So here we are going to be thinking about tooth-supported overdentures. In tooth-supported overdentures, you're obviously going to identify the teeth that you can retain because she's partially edentulous or he's partially edentulous, and the teeth that you want to remove. And this is going to be determined based on a couple of factors which we will talk about. Once it is determined, then we are going to determine if the health of the teeth is adequate, if the location of the teeth is amenable for our treatment, and if the number of teeth are enough for the treatment that we particularly propose. So where does it all start? It all starts with identification of the patient and identification of the abutment teeth as well as the compromised teeth. The abutment teeth should be something that has good periodontal attachment. Now if it's anywhere up to 20 to 30% attachment loss, I'd say that's okay, that's still amenable. But anything above 40% is really you're looking at the wrong tooth. Okay? So this is probably not the condition in which you find the patient. You probably find the patient in a state where there's a lot of inflammation and periodontal disease, but the abutment teeth should be one that you can identify that has got good attachment, and the periodontal condition must be amenable to periodontal therapy. So if you're not talking about something that is, really not going to work out, it's going to be something that we can manage we can do some periodontal therapy for, it's going to heal up, it's going to become firm, it's going to become reasonable. So that's the kind of teeth you want to select from the periodontal standpoint. Above 60-65% tooth loss, attachment loss, means that you're looking at a tooth that's highly mobile, and you're also looking at a tooth that's probably having a furcation involvement if it's a posterior tooth. And this tooth is definitely not going to survive any sort of periodontal therapy for our use in prosthodontics. So that's not a teeth you want to select. In terms of endodontic status, maybe this tooth is having calcified canals, maybe the tooth is endodontically treated already. If it is so, if long-term maintenance is desirable and this tooth is healthy enough to take that load, if you can do endodontic therapy and it will be okay, then these are the kind of teeth that you want to retain in the mouth. But if there is recurrent infection, periapical infections, you need repeated root canal therapies, you have unresolved periapical lesions, you have subgingival loss of tooth structure, tooth is broken and fractured down under the gingival level, even sometimes to the attachment. These kind of teeth probably are not the best choices for abutment teeth. So that's something you want to avoid. The third one is, once you've selected your teeth, then you're going to look at the location, we're going to talk about that. Once you've selected that your teeth are okay, then the question is the treatment going to be realistic? Okay. Now, in active old patients, you always have a good muscle tone. And if they have a good muscle tone, then they are going to be able to chew well. So a patient who's not having good muscle tone or neuromuscular control, I don't know if going through the process of doing overdentures is really going to help. So a patient who's predominantly sedentary, that patient, well, of course you can preserve the ridge by retaining the roots, but the level of attachment or the level of efficiency in the overdenture may be different in patients who are going for soft food or having difficulty with diet, poor neuromuscular control, and poor muscle tone. Patients with xerostomia. Patients like this obviously are not going to benefit much from your treatment. So they're not going to be very realistic in your treatment outcome. Also, patients who are not able to maintain their oral hygiene. These patients, all our procedures are going to create more problems rather than create solutions. So are there any strategies to mitigate problems in complete denture? Obviously there are, and which is why we are talking about overdentures, because in overdentures we are going to improve support and greatly improve stability. Now mind you that the first one, enhanced retention, it is not the focus of overdentures, tooth supported overdentures. So I want you to keep this in mind, because as we branch out further, you're going to have to think about this very clearly, otherwise you're going to lose focus of what you're trying to do. The tooth supported overdenture primarily has in focus as a goal the need to retain the residual ridge. So the root in place is so that the residual ridge does not resolve too fast, and this residual ridge is going to act as the support base for the patient's denture, the basal seat. Now once the tooth root are gone, we all know the periodontal ligament goes and the root starts shrinking, the ridge starts shrinking, and we don't have any ridges to place our dentures on. In other words, we don't have a basal seat. So this is what the tooth supported overdenture primarily needs to serve: retain the residual ridge as much as possible, or minimize the residual ridge resorption. Okay, so improved support and greater stability is the two aspects that are going to be outshining the improved retention when it comes to tooth supported overdentures. When it comes to implant supported overdentures, the patient is already completely edentulous, and now we are intervening at that spot to give some anchorage. That in that place we don't have any periodontal ligament in the implant, and so the mechanism happening there is different, and so there the whole anchorage idea is for retention, support and stability. There again the angle of support is less because you have only whatever bone is available, nothing more is increasing or nothing is really keeping it from resolving further except the attachments. Okay. So the possible improvements with overdenture, well, the improvements will be based upon retainable teeth and whether you want to give any attachments. When it comes to patients with completely edentulous or compromised teeth, obviously you're going to have to remove the teeth and then you're going to think about implants. Again, the number and location of the implant attachments that's going to come in. You're also going to think about bisphosphonate therapy, which is something most patients are taking for their osteoporosis or also for Paget's disease. So any patient on bisphosphonates, obviously, I have seen to develop eventually osteonecrosis of the jaw. So in a certain percentage, not obviously, in a certain percentage of patients. So in that case, patients either take bisphosphonates intravenously or they take it orally. So in the intravenous patients, and remember that this is a long-term therapy that exceeds 3 to 5 years, in intravenous therapy, definitely osteonecrosis of the jaw is something you don't want to play with, so I wouldn't suggest any sort of surgical intervention in such patients. In patients taking oral bisphosphonates, especially those that have exceeded 3 years of dosage, then again that's a place where you want to very cautiously proceed with anything that is going to be surgical because the bone reacts very adversely. So in these two situations, in situations where patients have been taking bisphosphonates, you preferably will retain the teeth that are there. So that's a call you have to make before you extract the teeth. So you need to know if the patient is taking any sort of bisphosphonates. If that is the case, you don't want to think about implants, you want to retain whatever is there because that is the safest bet for us. Okay. Going on from there, when do you identify a potential complete denture patient? Okay. This patient, as I told you before, should be able, obviously, financially to afford the treatment because you know that it's going to involve some periodontal therapy, some root canal therapy, and then some copings and maybe some attachments and so many things. So it's all going to cost them financially, and so the patient should be able and interested to financially afford the treatment. The patient should be able and interested to have better quality of life because that is the promise that overdentures actually give us. And so unless the patient is having a good mental attitude towards having a better quality of life, if the patient is just resigned and saying that, oh, that's it, I'm old, I don't want anything, then that's not the patient you want to try any of this in. Okay? And the third one, a patient who is able and interested to maintain remaining teeth in a healthy condition. And these are the kind of patients that you really want to look at. So obviously, you're looking at a philosophical type of patient or even an exacting type of patient. Definitely not a hysterical or a indifferent patient for that matter because they are not going to be good candidates for your therapy. So when we identify the problem teeth, let me just get into some of the specifics. You're going to look at, obviously when you say problem teeth, that means that most of the remaining teeth are not salvageable. So these are teeth that are going to go. That is because of severe attachment loss, because of mobility, because of advanced chronic periodontitis, and because of endodontic failures or fractures. And in this mobility I've highlighted because you must remember that when you reduce the tooth's coronal portion for overdentures, the crown root ratio is going to decrease and fall. And because the crown height is dropping, the mobility is going to come down very quickly. So that's going to be an additional help in your periodontal therapy because it's going to help the periodontium heal better because there are no lateral forces. It's going to help the attachment stay. It's going to help whatever adjuvant therapy you're going to do, and it's going to reduce the mobility as well. That's the reason why I put it like that. When it comes to long-standing loss of posteriors, you probably have adequate implant space because of the long-standing loss. That could work out in your favor. But you could also have unfavorably distributed or inclined teeth. That means that the teeth are all tilted or drifted, and so you can't do an FPD or an RPD. So this is how we would identify that. When it comes to compromised retention, you're thinking about poor residual ridges, obviously because of long-standing tooth loss and things like a class 1, class 2 situation for that matter. So poor residual ridges. Xerostomia, sometimes patient is not having enough saliva, which means that retention is a problem because we need salivary action in many ways to work to help retention. You also have a predilection towards caries and periodontal problems when there's less saliva, plaque and calculus formation as well. And you also, in situations where there is congenital or acquired defects, these are also areas where you are going to look at how you can enhance retention or how you have compromised retention because there is these defects. So obviously you're going to think or look for tooth that are going to help you enhance the retention here. So the next one is identifying the clinical condition. Here it is abutment teeth. So these are the teeth that you are going to look at for abutments. So you have some remaining teeth that are favorable as overdenture abutments, and in them you're going to look at teeth that are having not more than 30 to 40% attachment loss, and this is in the horizontal. So that means you're going to probe and you're going to look for probing depth. You're going to look at radiographs and you're going to assess from the radiograph if there's a calculation, as you all know, to know if there is more than 40% bone loss. Then you're thinking, okay, I'm going to decoronate this. So obviously that crown root ratio is going to drop, and so the mobility is not going to be much of a problem. So keeping that in mind, look for this. Obviously, when there's a vertical bone loss around a tooth that you want or you think is going to be a good abutment teeth, that is something you want to stay away from, because vertical bone loss is not really amenable to periodontal regeneration. So vertical bone loss with grade 2 or grade 3 mobility is definitely a red flag. But horizontal bone loss with grade 2 or grade 3 mobility, you may be able to still manage that, because with some periodontal therapy the disease can be arrested, and once the crown height is gone, the mobility comes down. When you come, that's why I told you, once you reduce the crown, the mobility is going to come down. So keep that in your mind. Don't lose sight of that. That's going to be very important for us. So the other thing is that it should be amenable to periodontal therapy. So a band of healthy attached gingiva needs to be there around the teeth after you do periodontal therapy. For example, sometimes you have some disease, chronic periodontal disease or refractory periodontitis and things like that, that are not really amenable to periodontal therapy, then that's the tooth you want to stay away from. So you really want a circumferential band of attached healthy gingiva, even if it's a narrow one, as mandatory for the selection of your abutment teeth. If the tooth is having calcified canals and not showing any signs of vitality, that's fine. But if it is vital, you probably need to go in for a root canal therapy, and you should be able to get a good apical seal. This means that if you have multiple canals and not able to access some of them because of one reason or the other, then that may not be a great selection. So you want to look for teeth that have canals that are accessible, that are well sealable. You cannot afford to have a periodontal lesion, periapical lesion, and then going back there. So that is something you want to think again. Another thing is a tooth structure that is broken down at the gum level. If it's broken down, we will need to place a post inside and kind of give it a small, tooth surface, okay? Not necessarily the kind that you would have for a fixed partial denture preparation, but at least a dome shaped or a thimble shaped surface. And so it may require a post depending on how deep the fracture is or the loss of tooth structure is. Oftentimes it just needs that you have a good apical seal so we can actually do a restoration and complete the tooth surface. That's the most important part. So if the apical seal is good, we can go ahead and restore the rest of the tooth and go ahead with it. So a good root canal therapy is important, with particular emphasis on the apical seal. Then when you come to the positioning, the strategic placement of the teeth is very important. Here you are looking at the bilateral placement. That is what you always want. The reason is because bilateral placement will always help distribute the forces across the two arches. The second one, you want this bilateral placement more towards the center of the arch than the back of the arch. And the reason for this is because the anterior portion of the mandible, especially the mandibular arch, is the one that is really susceptible to break down in terms of residual resorption. So because of this, you prefer to have two teeth up in the front that will prevent maximum resorption from that area. in case of maxilla also it holds true, because especially when you have mandibular natural teeth standing, then the mandibular natural teeth, as you know, is going to go into the premaxillary region and going to break down the bone in the premaxillary region. So you want to retain the tooth roots there so that the bone there is maintained. Another one is the fulcrum line. The fulcrum line is always better if it's perpendicular, right, or straight fulcrum line perpendicular to the sagittal than a diagonal one. It doesn't mean that you can't have a diagonal one, but definitely it's better off if this fulcrum line, obviously because there will be only one plane of rotation. The moment you have a side, then there's one plane downward and you also have a lateral plane. So the multiple planes as it comes in, you're going to have problems. And the number one thing you want to remember when you talk about a diagonal plane or having multiple teeth in different locations is that you are going to avoid any sort of retentive mechanism. This is my personal opinion. The more retentive mechanisms you're going to put into this, the more difficult it is going to be for your insertion. Maybe with 2 teeth it's okay, but more multiple teeth as they come in, it's going to get difficult. And the second thing is, when there's a lot of force talking around, then, and if it's locked into a sort of attachment, then the periodontal ligament, remember that this is tooth, and so there's periodontal ligament, so that's going to get constantly stressed out with the need to adapt to the new forces. And this sort of movement of the tooth every time the chewing is occurring because of the diagonal angle around which it's rotating is going to lead to periodontal breakdown. So we are actually going away from a fundamental goal of preserving the resorb bridge. It is for this reason that I said, when you talk about tooth supported overdenture, you really want to think about support primarily and stability more than you want to think about retention. So you're always thinking about a straight fulcrum line, not a diagonal one. Okay? As far as possible. When it comes to sound tooth structure, if you have good tooth structure, like I told you before, a good seal, maybe a good root canal, then maybe you can even go ahead with bare roots, with or without root canal therapy. It's not necessary that you have to put a coping on it. You could just plug the top with composite or with amalgam filling and maybe have a little extension to the root so that the filling is stable or strong. And once that is done, good topical fluoride. Obviously, before you send the patient, you want to really polish the surface really well, and then good maintenance topical fluoride should be adequately enough than trying to do any coping. You know, there is a huge controversy on trying to put a simple coping there, and I understand we tend to think that that's more safer and more somehow more hygienic, but the truth remains that the margins will always create problem areas for cleaning, much worse than trying to keep the tooth meticulously clean with a good brush. So that is one area that you want to think about. The other one is a thimble coping, which is a rather tall coping or a long coping. So there's a coping where it is going to give you some element of added stability because of its structure standing up like that. Multiple tooth like that is going to help the denture stay stable in a horizontal movement. So that is something you can think about. But again, if you're going to go very tall with your thimble coping, then remember that will be a problem because you don't have interarch space to arrange teeth. That will be a problem, so you want to limit that height. And you also are going to get too much talking force on each individual tooth. So maybe you don't want to go very tall on that. The other side is the attachments. I told you in a tooth support overdenture, you want to avoid attempting to go for this retention factor. You want to try to keep it simple with support and stability, and the patient usually is very happy with even that. But in case you think that you really need attachments, then you have simple attachments like the Sika attachment or a ball attachment. You can also have magnets. Each of them have their own advantage and disadvantage. The Sika, obviously, some element of resiliency, but not very resilient. The ball attachment will give you a much more resilient movement, and the magnets obviously are going to allow a lot more movement there. So depending on if you're using a tooth support overdenture, obviously you want to go for something that are not very rigid. You want to go for resilient sort of attachments. Okay, so this is what you would like to go. And of course there is the ZAG and the ZEST attachments, which are much more interlocking, much more tighter, much less resilient. I wouldn't really advise any of that. I would really advise maybe a ball attachment that will be, I think, the most versatile one in most clinical situations. But of course, you have the whole range from which you can choose. When it comes to complex attachments, you have all these bars and clips, and you have the header bar and clip, you have the Ackerman bar and clip, you have the Dolder bar and clip, and different people promote all of this. But my point again is that the moment you're going to put a bar and you're going to add a clip, you're going to add a lot more torque onto that structure, onto that thing. But the advantage in putting a bar is this: the two teeth or multiple teeth are going to get connected, which means that they can take load much better, which means that load distribution is much more better, which means that the per tooth loading is less, which means that actually periodontal support will be much better, because the tooth again cannot move in different directions based on the force. They are held together by this rigid bar. So the whole thing moves as one unit. So that's an advantage. So you can use a header bar, which is much more popular. It has minimal horizontal resiliency and no vertical resiliency at all. When it comes to Ackerman, you have minimal horizontal and vertical resiliency, which means the denture, as it's from the anterior to the posterior, this rocking movement, if it's just horizontal, that's a header bar, that's good enough for that. But if there is a tendency to really go down, then we are looking at some element of vertical movement as well. Then we are thinking about an Ackerman's bar. And you also have Dolder bar and clip, which is the U-shaped bar, which is rigid, and the pear-shaped bar, which is resilient. If you look at this, if I get a magnified picture there, if you look at that bar, on the first bar, you can see that it is tapering downwards. When it's tapering, it's a pear-shaped bar. The U-shaped bar is the one to the left of the diagram. So that one is got parallel side. So when the clip goes into the parallel side one, it's really rigid. It doesn't allow any rotation. So you need to choose which one you want depending upon your situation. So that is how we would look at our abutment teeth and what sort of attachments you want to come in with. So these are just some examples I wanted to put up. This is an example of a simple coping. It's not very tall. This is a ball attachment that you can clearly see. That's a thimble coping, and there's a mixture of thimble as well as a ball attachment. So you have an attachment fixed onto a thimble coping, and because there is a huge interarch space, this is going to work. But in cases where it is not so, this is going to be a real problem. You have a thimble as well as a ball attachment is going to stand above that. It's not going to be very feasible. So what about, like I told you before, you're going to either have a partially edentulous patient or a completely edentulous patient. What about the completely edentulous patient? Again, in this patient, if the patient has come to you early on, that means that you have some amount of ridge, you have reasonable ridge contour, and you have something that you can work with. But if the patient has come later on, then the question is, okay, there is no posterior ridge, there's only some anterior ridge, and even the anterior ridge is going to, you all would have seen a patient with a line anterior ridge or a depressed anterior ridge. So you're thinking, okay, I should do something so I can preserve this ridge and give some better attachment for the patient. So here, implant supported overdentures come into play. This would be the best sort of situation or therapy you would plan for a patient who is having, who is elderly and who is having resolved posterior ridges. So you're going to go for 2 or 3 anterior implants and going to make an overdenture. So it's going to be an implant as well as a tissue supported overdenture. The implant supported fixed complete denture, that's an option for a much younger patient who is able to maintain, who is active, who is able to take surgeries for multiple implants. That's where you have the all-on 4, the all-on 6 concepts and things like that, and I'm really not going to get into that because that is a totally different ballgame by itself. So here again, medical compromise is important to know, and you know if the patient is medically compromised and you cannot really do much. It all depends, okay? You can do a lot for patients who are diabetic, who are controlled. The HbA1c is going to give you a lot of detail, and CBCT is going to help you plan your treatment well. What are you going to look for is the quality and the quantity of the bone, the number of implants, and the location of implants. For the quality of bone, obviously you know that there are 4 types of bone. Mish has spoken about here, the D1 to D4, and you know how to categorize that. But when you see the patient, you probably are first thinking about the quantity of bone. And that's where we need to think about the bone in different areas. So we divide the mouth into the anterior region, the right posterior, the left posterior in the mandible, the anterior in the maxilla, the right posterior and the left posterior. Here what you need to remember is the maxillary sinus. It's probably going to give you a problem because this height decreases as the resorption occurs, and the sinus sometimes becomes slightly larger, and so the amount of bone height here can reduce drastically. The anterior region also, depending on the time of edentulousness, which tooth was retained to the end, will determine how much bone is left. But the anterior portions are the safer portions for your implant placement, and for this reason, when we talk about implants about overdentures, we are always concentrating on placing implants in the anterior segment. So the type 1 bone is the bone where the volume of available bone is similar in all 3 segments. The type 2 bone is where the volume of bone available is similar in the posteriors but is different in the anterior. The type 3 is where the volume of available bone is dissimilar in all 3 segments. So this is how we want to classify that if you're thinking about going in for implants or calling in somebody to do implants or whatever is the situation. This is how we want to classify that. The number of implants are going to be determined by mapping the mandible, especially this is the ideal treatment is really implant support overdentures for the mandibular arch because the mandibular bone is smaller. You could do it on the maxilla too. But here again, you're going to look at the mental foramen, and then you're going to decide the position A to E, where it is 5 millimeters anterior to the mental foramen is where A starts and E starts, and everything else is in between, B, C, D, E. And these locations are the locations we are going to really use for an implant placement. When you think about location of implants, like I told you before, there are all these different possibilities, and the OD1, which is basically placing implants in the B and D positions, which is away from your mental foramen, okay, and usually with a ball attachment. OD2 is where you have it in B and D, but you have a bar attachment. But you need to be important that you don't have a distance less than 20 millimeters. A minimum of 20 millimeters gap should be there between the 2 implants. OD3 is 3A is where you have 3 implants, A, then C right in the center, as well as E, and is connected by a bar. Usually this bar is slightly curved, so that is why you see that sort of a split bar. It's not a split bar, it's just a curved bar, okay? And so that really gives you an understanding as to how the clips are going to get placed, because you don't want 2 clips working against each other. So if you're going to have a bar that is more angular, then you're going to look at 1 clip. Because you use 2 clips in that situation, you're going to have more wear and tear and frequent replacement of the clip and all those things. So usually 1 clip will be what suffices there, and you could probably alternate. When 1 clip is gone, you could use the other side. Okay. So OD3B is where implants are placed in B, C and D positions connected by a bar. Again, it can be a straight bar, it can be a curved bar. Again, preferable to be a straight bar. OD4 is where you have implants in A, B, and you skip C and D, E positions with a 10 millimeter cantilever. Now this is the all-on-4 kind of a story, or you can even extend this to go on to all-on-6, which is much more preferable in terms of weight distribution. But then the 6th implant, 5 and 6, is going to have to be somewhere in the posterior region, which is where the resorption is going to be greater, so you need to plan that out. OD5 is where you have 5 implants in A, B, C, D, E positions, and a cantilever that can go up to 15 millimeters. Now the thing is that whenever you cantilever, obviously you know that there's going to be a lot of loading in the posteriors because the patient is going to eat and chew on the posteriors. For this reason, keeping the cantilevers within 15 millimeters is really ideal. You don't want to go anywhere further from that. So that really brings us to implant support overdentures, the quality, the quantity of bone, and the location of the implants. Having this in mind, you can plan out how many patients you are looking at. Is this patient good for an overdenture, which is tooth supported, or should I go in for implant supported? The moment it comes to implant supported, you can remember all the attachments I spoke about. All of them are feasible. From the ball to the ceca, the bars, all of them are feasible, because in the implant retained overdenture, we are really looking at added support but we are also looking at retention. We are also looking at some element of stability. Because there's no peroneal ligament, your forces are going to get transmitted directly to the bone. So there's going to be some bone remodeling, which is much more slower than when the peroneal ligament is there. And for this reason, it is maybe feasible to have some sort of attachments built into your implants. Thank you.